أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما رب يسر ولا تعسر وتمم بالخير رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear all, Assalamu alaikum. All, I hope all of you are in good shape and observing the holy month with all your efforts. And before discussing this new topic, I would like to inform you that during this April monthly test, number of students they had not appeared. So they must submit their reason, otherwise their parents be informed because of their lack or in their interest. So after that, another very important thing is that number in the MBBS result, what we have observed that around 40 students last year they joined as third year MBBS after their supply exam. They were around 40 students. By the grace of Allah, the result of pathology, forensic medicine, and behavior sciences, they remained 100%. None of the students failed in the annual examination. While some people, they couldn't go through the pharmacology anyhow, even then out of 48 students, they couldn't clear in pharmacology. I hope while those students who cleared this supply in second year, they are rather 2 or 3, even 1, 2 or 3 supplementaries in different subjects. But by the grace of Allah, due to the input of your teachers and the blessing position of the principal Sahib, so Allah made it possible to give such a nice result. And at the same time, it's also something very important to share with you that in second year BDS pharmacology result, only one student couldn't go through while all others they cleared. Rather, one student got distinction. There are also in MBBS 6 distinctions in pharmacology. So the purpose of informing about it is that you must work hard, never lose heart, even if someone has supply in second year. So inshallah, we will work together. You must stay in touch. Give us 90% at least your attendance, and by the grace of Allah, your result will be 100%. Well, coming to the pharmacodynamic after pharmacokinetic and general introduction about the pharmacology. These are introductory lectures, and these are the basic lectures. I always say that you must go thoroughly through the 3 or 4 first chapters of the Katzing, and that's review as well as the main Katzing. So to have a proper foundation. So about the part of the pharmacodynamic is about what we will discuss over here. These are the spare receptors. It is about the spare receptors and how they are regulated. You haven't taught about these receptors in different lectures by different teachers. They have gone through it. Also part of it we will discuss it, spare receptors. As the name indicates, those receptors which are not occupied, but even at that time the maximum effect of a drug is achieved. The clinicians, they are concerned with the maximum effect. So we will go through these slides, we will discuss it. Inshallah, I hope all our students will be fresh, and you must have a pencil, a pen, and a copy in your hand. So the things which are not written over here, you should also note. So we are going to. So what's the purpose of teaching about the spare receptors? You have to define it. What's spare receptor, and explain the spare receptors with the help of one example and a graph. Then how spare receptors can be demonstrated experimentally. We will go through the coming slides, so how they are demonstrated. What is upregulation of receptors and what is down-regulation of receptors, and few examples. We will go through it. Next, what else you should know it about the EC50. EC50 means the concentration which is producing effect in 50% of the effect, or ED, effective dose 50, a dose which is producing 50% of the maximum effect. So it is a concentration or dose of a drug that produces 50% of the maximum. First, let it be in your mind that as you go on increasing the dose, the effect, if it is you make it on graph, so it will go on increasing, but at a certain level there will be no more increase in the effect. So 50% of the maximum required effect. The required effect may be therapeutic, clinical. It may be toxic. Toxic effects seen in animals are the lethal effect. So it is known as also there is one abbreviation Emax. Max means maximum efficacy. You have been told that efficacy, clinicians, they are more concerned with efficacy rather potency. Note down these things. We will show you the graphs, and then it would be easier. Rather earlier in some lectures these things are being discussed. Maybe repetition. Next, in quantal dose response curve, here you see, in contrast to quantal dose response, the first one is another one is the graded dose response. Means you are increasing the dose and the responses. In case of quantal dose response curve, it is the percentage seen in a population. Quantal dose response curve. It is the concentration or dose of a drug that produces specific response. Quantal, specific. A specific response is there. Say death is there of some animal or death is not there. Cough is suppressed or cough is not suppressed. Headache is relieved or headache is not relieved. So it is something all or none. Arrhythmia is there or arrhythmia is not there, like that. These are the specific effects. And in quantal dose response, it is the population, which is the percentage of the effect that is observed. Quantal dose response curve, it is the concentration or dose of a drug that produces a specified response. A specific response is in your mind, you are going to have in 50% of the population under study. Here a population, a group is studied. In graded dose response from individual case, you go on increasing says you see the effects in our laboratory on the rabbit intestine. So you go on increasing the dose of acetylcholine and see what happens to uh, the intestine, and you can make a graph of that. So another term is the given over as a KD. It is related to receptor occupation. KD. It is the concentration of drug that binds 50% of the receptors. KD is related to receptors occupation, where 50% of the receptors they are occupied in a system. So abbreviation is there KD. Note down, it is about the concentration of drug that binds 50% of the receptors. These are two graphs over here. The drug concentration at which effect or receptor occupancy is half maximum are denoted by EC50. The same 50 we have already discussed. And KD respect. In EC50 concentration which is factored in at 50, half of the, say over here example you can see on the left side we are making a graph. On left side it is a change in heart rate. You go on increasing the dose. Log of the dose is given along the x-axis or abscissa. Note down x-axis, this is the lower side, x-axis or the abscissa, and the response is seen on the y-axis or the ordinate. But I remember it is ordinate, y-axis. So in the y-axis, it is written over here, change in heart rate, beats per minute. You know normal beats are says in human being it is 72. So its graph is made. It's a log scale. A log of a dose is taken along the x-axis and so effect is seen. Here you see maximum effect is there, and while we are concerned with the concentration, effective concentration of a drug which produces 50. Here you see the 5 is given as the effective concentration. On right side, it is about, here you see the percent of receptors bound. What KD? KD, you know the percent of receptors bound. Here again you see the maximum receptors they are occupied shown over here, and KD even over here KD is again 5. Dose given along the x-axis or the abscissa, it is again 5. So in those two examples, KD and EC50 are the same. It is the same dose which is producing the 50% effect, whether it is the occupation of receptor or it is the change in heart rate. Next we come to the spare receptors, also known as receptor reserve. There are also theories about the receptor. I think you have not been told about it. There were in previous books these theories were written, spare receptor theories, spare classical spare receptor theory and like that. There are around 3 theories about it, red theory and like that. Have a look on that if you find in your book. Sphere receptors are receptor results. Sphere receptors are said to exist if the maximum response is achieved, even with a dose which occupy less receptors, but the response is maximum. Sphere receptors are said to exist well the maximum response with the drug is achieved by an agonist at a concentration that does not result in occupancy of all of the available receptors. It means that all the receptors are not activated, they are not occupied by an agonist, but the effect maximum is achieved. So in this case, the Kd is more than the EC50. Kd is more than the. These sphere receptors, these are the receptors present in a particular tissue in excess of the receptors, actually needed to elicit the maximal biologic response. One example is in heart, where all the say beta receptors they are not occupied and the maximum response is achieved. These are the receptors present in a particular tissue in excess of the receptors actually needed to elicit the maximal biologic response. And next, here is again one dose response curve. On left side is the percentage of the maximum, percent of the maximum, and on lower side it is the log of the dose. So here you see in case of Kd is more than EC50. Kd is more than AD50. Just have a look. Kd is 10, and while this is about the receptor occupancy, while this effective concentration is 1. These are just the numbers. So Kd is 10, and or in other shape you can also write it down like EC50 is less than the Kd. Kd is about the drug binding, while the EC is the drug effect, EC50. Sphere receptors, how they are demonstrated experimentally. Sphere receptors are demonstrated by using irreversible antagonists. Note down one example of irreversible antagonist. Note down please. Phenoxybenzamine. This is one alpha adrenergic receptor blocker. Phenoxybenzamine. This is one example, even other examples. Experimental sphere receptors may be demonstrated by using irreversible antagonists to prevent binding of agonists to a proportion of available receptors and showing that high concentrations of agonists can still produce an undiminished maximal response. Here you see irreversible antagonist, you know about the different bonds. Irreversible. So the effect of this antagonist, the effect is longer, but at the same time, it is given over here that you increase concentration of agonist, and again the response is there. It means sphere receptors are available in that case present. Concentration of agonist can still produce an undiminished maximal response. So one irreversible antagonist is there. Even as a rule, there should be no more effect. But here, if you are going You are increasing the concentration of agonist, so even then response will increase, maximum response that will increase. Well, after that, here is another example. The same maximal inotropic response. What is inotropic? Note down, force of contraction. Another thing related to it, you might have studied in physiology, chronotropic, note down, chrono. It is about the speed, inotropic response of heart muscle to catecholamines. You know the catechol. What are catecholamines? Note down. You must go through it. Catecholamines. Okay, they have got catechol ring. Can be the heart muscle. Inotropic response of heart muscle to catecholamines can be elicited even when 90% of beta-adrenoceptors to which they bind are occupied by an irreversible antagonist. Say you give one irreversible antagonist, and even after that you give catecholamines and the effect is overcome and it is increased, so it means the spare receptors are there. Going again through it. Same maximal inotropic response of heart muscle to catecholamines can be elicited even when 90% of beta-adrenoceptors to which they bind are occupied by an irreversible antagonist. Again, over here is irreversible antagonist. You block them, then by giving catecholamines, increasing dose of catecholamines, the same maximal inotropic response can be achieved. After irreversible antagonist, you block the receptor. It means that accordingly, myocardial cells are said to contain a large proportion of spare beta-adrenoceptors. It means spare receptors were there, which were stimulated by giving catecholamines. What counts for the phenomena of spare receptor? Phenomena of spare. This might result. Why it how is it proved? This might result from one of two mechanisms. There may be one mechanism involved in this. The actual number of receptors may exceed the number of effector molecules. You have gone through in detail. There are receptors, there are effectors. In detail you have been taught by Professor Mariam Rashid. So the actual number of receptors may exceed the number of effector molecules available. I mean, here you see how many receptors are there, how many effectors are there. This is one thing. But one of two mechanisms. Second one, the duration of activation of the effector. The duration of activation of the effector may be much greater. Duration of activation of the effector may be much greater than the duration of the drug-receptor interaction. The total duration of the drug-receptor interaction is less, while the duration of activation of the effector may be much greater. Here is another reason about the explanation note. Please kindly check this spelling of explanation. I is not there, what I remember. Explanation. Kindly go through explanation of the spare receptor concept with the help of an example. Again, some example is here in the next slide. Imagine a responding cell with 4 receptors and 4 effectors. Just imagine, there are 4 receptors and corresponding with the 4 effectors. Here the number of effectors does not limit the maximal response and the receptors are not spare in number. Here you see 4 receptors and onward there are 4 effectors, so it means there are no not spare receptors in this case. Consequently, an agonist present at a concentration equal to the Kd will occupy 50% of the receptors and half of the effectors will be activated, producing a half maximal response. Again going through. Consequently, an agonist present at a concentration equal to the Kd. One agonist is there at a concentration equal to the Kd. I mean the dose which occupies 50% will occupy 50% of the receptors and half of the effectors will be activated, producing a half maximal response. Then that is 2 receptors stimulate 2 effectors. That's true. Next. Again imagine that the number of receptors increases tenfold to 40. Already they were 10 and now they were 4 and then it is tenfold. They say that the receptors are 40. But the total number of effectors remains constant. At the same time, the effectors are just 4. Most of the receptors are now spare in number. That the number of receptors increases, for example, number of receptors they increase 40 to the rest, while the effectors they remain 4 as already given. So it means the receptors, spare receptors are there, most of the receptors are now spare in number. As a result, a much lower concentration of agonist suffices to occupy 2 of the 40 receptors. As a result, a much lower concentration of agonist suffices to occupy 2 of the 40 receptors. So 50% of that means 5% of the receptors. 5% of the receptors. And this same low concentration of agonist is able to elicit a half maximal response. 2 of 4 effectors activated. 2 of 4 effectors activated. Thus it is possible to change the sensitivity of tissues with receptors. Very important. Thus it is possible to change the sensitivity of tissues with spare receptors by changing receptor number. It is possible to change the sensitivity of tissues with spare receptors by changing receptor number. Importance of spare receptors. What's the importance? The spare receptors are there. They allow maximum response to be produced without occupancy of all the receptors. Maximum response can be produced even without occupancy of all. This is one important. Second, the presence of spare receptors increases sensitivity to the agonist. Presence of spare receptors increases sensitivity to the agonist because the likelihood of a drug receptor interaction increases in proportion to the number of receptors available. Because the likelihood of a drug receptor interaction increases in proportion to the number of receptors available. This is about the importance of how the receptors they are. Here you go. Receptors are dynamically regulated. Their, number increases, number goes down, location, maybe change, sensitivity of receptors, that increases, that goes down like that. Receptors are dynamically regulated. There is change in that, dynamically regulated. Their number may increase or their number may decrease, and location may change. Location and sensitivity may increase or decrease. Number, location, sensitivity. What is the dynamic regulation? Change in numbers, then about the location and the sensitivity. Changes can occur over short time. In very short time, the changes may occur in these receptors, or there may be a longer period, say for days. What is down regulation? As the word shows, down means the number of receptors that increase. It is the decrease in number of receptors may occur in response to continuous exposure to agonist or nerve stimulation. You are giving agonist. You're going on giving agonist or nerve stimulation. For example, you are stimulating beta 2 receptors. You're going on it. So there is possibility, or you're stimulating beta 1 receptors. So the number of receptors may go on, or you are stimulating, not stimulation is there. So in the result, the therapeutic response will decrease. As the number of receptors, they will decrease. Therapeutic response will decrease. There will be refractoriness over weeks or months. With the passage of time, so there will be refractoriness, no response. Then the vanishing receptors are taken into the cell. So where those receptors have gone? They have gone inside to the cell. That is known as, endocytosis. This word you have already read somewhere earlier. Endocytosis, exocytosis. Over here it is the endocytosis of this is one thing about down regulation. Another thing, endocytosis word related with the internalization. Then in this case of down regulation, recovery is slow and may take several days. Recovery is slow and may take several days. One example, like a prolonged use of big agonist, decrease number. Beta 2 receptors agonist given in asthma. So this is one example. And in certain cases, there is no further dilatation of lungs by giving the beta 2 receptors, or maybe beta 1 receptors, next one regulation. In contrast to the down regulation, there is upregulation. As the word shows over here. Number of receptors, they will increase. It is increase in number. It is in contrast to the down regulation. You are, say, giving some antagonist. It occurs when receptor activation is blocked for a prolonged period. You are giving some receptor, beta 1 blocker you are giving, or some antagonist you are giving for a longer period. So there is denervation of some area, of some muscle. So what will happen? The chronic use of beta blocker increases the number of beta. In case of certain drugs, which are, say, given for to bring down the blood pressure, they say beta blockers are given to bring down the blood pressure. So all of a sudden you leave them So at the same time there is upregulation, number of receptors increase, so there will be sudden withdrawal and the blood pressure that will shoot. Sudden withdrawal of so the antagonist should not be withdrawn. There are number of these examples are there. One is clonidine for blood pressure should not be stopped all of a sudden. Then calcium blockers, they should not be stopped all of a sudden. Like that. Sudden withdrawal of the antagonist can be dangerous, as increased chance will be seen due to increased number of receptors. Very important. As you give medicine to your elders, so be careful. Sudden withdrawal of certain medicine, you should be careful at that time. May be dangerous. Here are some example pictures are given. Before drug treatment, the number of receptors, the normal number of receptors. After chronic agonist, what happened? Number of receptors they have increased to 2, and say after chronic antagonist, so there is upregulation. So number of receptors they have increased, as you see in the picture. There are a few more examples. What is autoreceptors and heteroreceptors? Auto. There is autoregulation. You know the catecholamines or the acetylcholine release, but at the same time, they are also manipulated by a system and how to control it. Autoreceptors and heteroreceptors. We go through. Autoreceptors, they are presynaptic receptors. They are presynaptic receptors that respond to the primary transmitter substance released by the nerve ending. As acetylcholine is released, noradrenaline is released. So autoreceptors, they are at the presynaptic site. They respond to the primary transmitter substance released by the nerve ending. Autoreceptors are usually inhibitory. They have got inhibitory effect on the neurotransmitter. For example, M1, M2, A2. M1 muscarinic 1, M2 is muscarinic 2, A2 adrenergic, so 2. But presynaptic beta 2 receptors, again one example, presynaptic beta 2 receptor facilitate the release of norepinephrine. So this is one strange example. If the presynaptic beta 2 receptors are present, they facilitate the release of norepinephrine from some adrenergic neurons and some cholinergic fibers, especially somatic motor fibers. Somatic motor fibers have excitatory nicotinic autoreceptors. Somatic motor fibers, they have excitatory nicotinic autoreceptors. Just go through it, please. Remember it. Then heteroreceptors. These may be activated by substances released from other nerve terminal that synapse with the nerve ending. Say with one nerve ending, another nerve terminal is coming. So the receptors at the presynaptic site, they are also heteroreceptors. They may be activated by substances released from other nerve terminals which are close to that synapse with the nerve ending. Example given over here, some vagal fibers, vagus nerve, vagal fibers in the myocardium synapse on sympathetic noradrenergic nerve terminals. Some vagal vagal fibers in the myocardium. Vagal fiber in the myocardium synapse on sympathetic noradrenergic nerve terminals and inhibit norepinephrine release. This is something very important. You know there is balance between the cholinergic system and the adrenergic system. Here you see that some vagal fibers in the myocardium synapse with the sympathetic and noradrenergic nerve terminal, so they inhibit norepinephrine release. Here pictures are given on left side. You see acetylcholine is released at the synapse, and before that again at the presynaptic side autoreceptor of acetylcholine is there, so which has got a control on that. And another thing is at presynaptic receptor side heteroreceptor, you've been told that other nerve terminal has a synapse with this terminal, so heteroreceptor. On right side is a adrenergic nerve terminal. Again norepinephrine is being released, and the autoreceptor, it has got a check on that at the presynapse. Even here the heteroreceptors are shown. These two pictures are very important. You must draw them again and again, and how acetylcholine is formed, how is it stored, how is it released. Similarly, how the this noradrenaline is being formed, how the different steps you must know, and at what step what drug is acting. So these two pictures are very important. You must draw again and again. And coming to the next, there are certain MCQ1 is, here you see the graph. Prior to clinical trials in patients, you are well familiar with the present situation. These vaccines are given. So there are different steps of the research. Well, prior to clinical trial in patients, you know the drugs they are tested on different animals, different species. Data is collected, their safety, efficacy is checked. Prior to clinical in patients with heart failure, an animal study was carried out to compare two new positive inotropic, inotropic, A and B, to a current standard agent, or standard agent is there, C. The results of cardiac output measurements are shown in the graph below. So you have to interpret which one is more potent, which one is more efficacious, and you have to compare with the graph. These are sigmoid shape, a graph sigmoid. Another one is hyperbolic. Sigmoid when it is log of a dose is taken. Log of a dose is hyperbolic when it is just a dose along the. Which of the following statement is correct? Drug A is most effective, drug B is least potent, drug C is most potent. What is potency? You should know. Drug B is more potent than C and more effective than A. Drug A is more potent than B and more effective than C. What is potency and what is efficacy? You are MCQ2 is this. Several studies have indicated that in humans and experimental animals, about 90% of cardiac beta receptors are spare receptors. We have already discussed that. 90% of cardiac beta receptors are spare receptors. Which of the following statements about spare receptors is most correct? Spare receptors, in the absence of drug, are sequestered in the cytoplasm. Spare receptors may be detected by finding that the drug-receptor interaction lasts longer than the intracellular effect. Spare receptors influence the maximal efficacy of the drug receptor system. Spare receptors activate the effector machinery of the cell without the need for a drug. Sepal receptors may be detected by the finding that the EC50 is smaller than the KD for the agonist. You have to go through the lecture again and again to understand it. There may be half. Thank you very much. Khuda Hafiz.